Hello, my name is James Brown. I'm Division Head of Adult Reconstruction at the University of Virginia. And for the next hour, I'm going to speak with you about adult reconstruction of the hip. Now obviously in a relatively short period of time like this, we don't have the ability to cover every potentially testable item. But I'm going to try to cover what I think is the most important thing for you to know as we go forward. My disclosures are listed on this slide. We're going to jump right in with primary total hip arthroplasty. Now the surgical approaches to total hip arthroplasty are very testable topics, and it's important that you have a good, solid understanding of the muscular intervals, the nervous intervals, the pros and the cons of all four of these approaches. Now we'll review each one of these in detail, but I have this slide here for you as a summary. The anterior approach is the only approach that has a true internervous interval. The intramuscular interval is between the tensor and the sartorius, as is depicted here. And of course, the direct anterior approach goes by a number of different names, including those that I have listed. Now, the path of the anterior approach superficially passes between the sartorius and the tensor fasciae lata, and deep in between the rectus and the gluteus medius, as is depicted in this slide. Now, question writers love to test complications, and this is particularly important when it comes to the surgical approaches. You want to understand that the lateral femorocutaneous nerve is the most common complication, the most common nerve injury with the anterior approach to total hip arthroplasty, and this can result in thigh numbness. The ascending branch of the lateral femoral circumflex artery is also in play, and this can lead to significant bleeding if not cauterized during the exposure. The exposure of the femur can be very challenging, and this is why it's often a potential to result in varus position of the stem or undersized stems. So femoral exposure can be very challenging. I've again summarized the direct anterior approach on this slide with the muscular intervals and the internervous plane between the femoral nerve and the superior gluteal nerve, and the pros and cons are listed. Certainly stability is a pro of the direct anterior approach, as it is with all anterior approaches, as well as rapid muscle recovery. The downside, of course, again, is the challenging femoral exposure and the possibility of needing a special table. The lateral approach, or the direct lateral or modified Harding approach, as depicted here, this involves splitting the gluteus medius between the anterior 1/3 and the posterior 1/3. Now, superior exposure can be difficult. Superior extension past 5 centimeters outside of the so-called safe area puts the superior gluteal artery and nerve at risk, as is depicted in this slide. The lateral approach, the muscular interval, is between the, involves vastus lateralis splitting as well as gluteus medius splitting. There is no true internervous plane. The benefit, again, the pro is stability. The downside is prolonged abductor recovery. Again, proximal extension can be challenging. The anterolateral approach, or the so-called Watson-Jones approach, is depicted in this slide. This approach involves going anterior to the gluteus medius. There is no internervous interval. The pro, again, is stability, as with all anterior approaches. The downside, femoral exposure can be challenging. The tensor fasciae lata can be denervated, and the gluteus medius can also be injured if not done carefully. The posterior approach, which remains the most common approach to total hip arthroplasty, which is probably most familiar to the audience, the aspects of this approach are listed on this slide. It involves a maximus split and external rotator tenotomies from the back of the femur. There is no internervous interval. The advantage to this approach, of course, is that it's quite extensile both proximally and distally, and recovery can be quite quick. The downside of the posterior approach historically is instability. Now that may be changing with larger femoral heads, but again, for the purposes of the test, I think posterior approach should be associated with instability. Let's move on to total hip arthroplasty fixation. Now, whether you cement or you use a cementless technique is controversial. Certainly in North America, cementless fixation remains the mainstay with total hip arthroplasty. I think a lot of us have concerns about the long-term results of cement, particularly in our younger patients. If you look at the results of the Charnley cemented arthroplasties, the data clearly suggests that cemented cups tend to fail at a higher rate than cemented stems, and that has been a popular test question. And there's, of course, no potential to remodel with cement. Now, on the femoral side, I think cementless or a well-done cemented femoral stem is acceptable. On the acetabular side, cementless fixation, I think, is certainly preferred in the North American market, and this involves using a hemispherical cup with or without screws. Now, bone ingrowth or bone on-growth is critical to the success of a cementless technique. Bone grows into the porous structure of the metal. There are multiple options for how to achieve bone ingrowth, whether you use beads, mesh, fiber metal, etc. These are often attached to the cup itself using high temperatures. Now, there are three main requirements for bone ingrowth, and I've listed those here. Number one, and this is somewhat obvious, live host bone is required. So if you're given a question that involves a patient who's had a radiation, I would not check the box that uses cementless fixation. With some of the newer highly porous metals, that may be changing, but for the purposes of the test, if you have a radiation, I would pick a cemented option. Number two is you need an appropriate material. You need appropriate porosity. If you have too much porosity, the surface can actually shear off of the cup. Too little and the bone won't grow in. I've listed the necessary pore depth as well as the gap. The pore depth needs to be between 50 and 150 microns to adequately achieve ingrowth, and a gap of less than 50 microns is required. Number three is no motion. If there's any motion in between the implant and the host bone, then fibrous ingrowth can occur. Greater than 150 microns is where we start to get into trouble. Let's talk a little bit about cementless stem design. Titanium is the most common material used in cementless stems. This is more flexible, similar to the elasticity of bone. This can result in less stress shielding and thigh pain, which is what we would occasionally see with stiffer cobalt chrome implants. Circumferential coating is important. It reduces the effective joint space, reduces the potential for osteolysis. Both ingrowth or on-growth surface finishes have been successful, and proximal or distal fixation can work. Stress shielding is an important concept to understand. This involves when a stem is distally fixed. We often see this in cylindrical, fully porous coated stems. Larger stems tend to be stiffer, and this can result in more stress shielding. Cobalt chromium is the typical culprit when we talk about stress shielding femoral implants, and I've listed some of the factors that go into determining the stiffness of the stem. You should be familiar with an X-ray appearance of a stress-shielded stem. We typically will see distal sclerosis and spot welds where the stem is well ingrown. This is the point of stress transfer between the stem and the host bone. Proximally, the bone is unloaded, and we see osteopenia in this area. Remember this image as we talk about osteolysis later. The appearance is different than osteolysis. Hydroxyapatite is an important surface coating to be familiar with. I've listed the chemical structure here, which has been tested in the past. Remember that hydroxyapatite is osteoconductive. It is not osteoinductive. And I've listed some other characteristics here to be familiar with when it comes to hydroxyapatite. It is important to remember that this is a surface coating. It can delaminate off the stem if ingrowth does not occur through the hydroxyapatite and into the stem underneath as well. Modular neck femoral stems have lost their popularity recently, but were in fairly widespread use a number of years ago. I think it's important to be familiar with this implant. They were designed to increase the ability to restore biomechanics and hip stability through these interchangeable modular necks. The problem with these implants included corrosion at the modular interface as well as fractures of the neck and stem. Several of these implants have now been recalled. Moving on to the cemented femur and implant design. When it comes to cemented implants, flexible materials have not performed as well. Titanium, for example, tends to be flexible, and it leads to bending stress on the cement mantle. This can result in cracking of the cement mantle and loosening. Avoiding sharp edges is important. Some of these tapered, smooth implants compress the cement and have a good long-term record. Pre-coated and roughened cemented stems have not performed as well due to the preferential failure rate of the cement and bone interface. These roughened and pre-coated stems bond almost too strongly to the cement mantle. Polyethylene it's important to understand a number of different properties of polyethylene, which we'll talk about here. A couple of key concepts to remember is that cross-linking improves wear. We'll talk about the manufacturing process that's involved with polyethylene. It begins with irradiation. This leads to a generation of free radicals and cross-linking. These free radicals then need to be eliminated so that further oxidization does not occur. This can be done with reheating or melting. Free radical scavengers such as vitamin E have also been used. And then finally, the polyethylene needs to be sterilized before it can be used in humans. This is a cartoon depiction of cross-linking of polyethylene. You can see that as irradiation is applied to the polyethylene chains, hydrogen radicals are formed, which leads to cross-linking of the chains. Now, There are always residual free radicals that remain, and these need to be dealt with to avoid oxidation. The polyethylene can be subsequently melted. This is a highly effective technique to remove free radicals. However, it does reduce mechanical properties. Annealing of the polyethylene is another technique that can be used. This involves heating the polyethylene to its sub-melt point. While this maintains mechanical properties, it is less effective at removing free radicals. Vitamin E is a biological antioxidant that a number of manufacturers have used to add to their polyethylene as well to scavenge free radicals. Now, this is an important slide and an important concept to remember. There is a trade-off to irradiation. As the dose of irradiation goes up and the cross-linking goes up, while the wear resistance improves, the mechanical strength decreases. And that's a key trade-off to remember when it comes to irradiation and cross-linking of polyethylene. Now, the clinical outcomes looking at cross-linked polyethylene clearly support decreased wear in vivo. A number of clinical studies have confirmed superior wear characteristics of highly cross-linked poly compared to conventional polyethylene. Approximately a 90% reduction in the wear and dramatically reduced rates of osteolysis. When it comes to polyethylene manufacturing, there are a number of different techniques that can be used to manufacture these implants. There are two major categories of manufacturing for polyethylene. Either the polyethylene is machined into the final shape, or it's directly molded through direct compression molding techniques. In general, direct compression molding techniques seem to have a better track record. Calcium stearate, which is an industrial lubricant, was added to polyethylene. This turns out to be a bad idea. Gamma radiation and air is also a bad idea when it comes to polyethylene manufacturing. The irradiation process needs to be done in an inert environment to avoid oxidation. Let's move on to component positioning in total hip arthroplasty. It's important to know where to put the implants. On the acetabular side, we speak of the so-called safe zone. This involves trying to put a cup in at about 40 degrees of abduction, the range being from 30 to 50 degrees. And in terms of anteversion, you want to aim for approximately 20 degrees, somewhere between 10 and 40 degrees. On the femoral side, we shoot for 15 degrees of anteversion. The range between 5 and 25 is generally accepted in terms of getting the implant in the so-called safe zone. Now remember that the direction of dislocation is the direction of excess. So if a hip dislocates out the front, in all likelihood that patient has excessive combined anteversion. And combined anteversion is an important concept. It's not only about the cup and it's not only about the femur, it's really about the relationship of anteversion of the acetabulum to the anteversion in the femur. And our goal for the combined amount of anteversion is about 35 to 45 degrees, as is depicted here. Now, range of motion to impingement is an important concept. The femoral head size and the head to neck diameter ratio are important concepts that we'll talk about in some detail. What you need to do when putting in parts for a hip replacement is maximize that patient's range of motion until the parts begin to impinge. And typically we're talking about the femoral neck on the acetabular component. Increasing the femoral head diameter and increasing the head to neck diameter ratio is the most direct way to improve range of motion to impingement, assuming that the implants are put in correctly. Jump distance is another important concept to understand. The larger the diameter of the femoral head, the further that femoral head has to displace before it can leave the acetabulum. And that's clearly depicted here. So the larger diameter of femoral head, the less likely, or the increased distance that femoral head has to travel before it exits the acetabulum. So it's easy to understand why as we increase the femoral head diameter, we increase the jump distance and we increase our stability. You can see with a 28 millimeter head, that head has about 14 millimeters it needs to travel before it dislocates. With a 38 millimeter head, of course, that jump distance goes up to 19 millimeters. Anything that decreases the range of motion to impingement can increase the risk of dislocation. I've listed a number of those things on this slide. Lipped or hooded liners, skirts or collars, constrained liners, and of course malposition components can also decrease range of motion to impingement. It's important to understand that wear refers to the progressive loss of material due to relative motion between surfaces. This can be at intended surfaces, such as between the femoral head and the acetabular polyethylene liner, or it can be at unintended surfaces. When hips dislocate or subluxate, we can encounter stripe wear, we can get backside wear between the polyethylene and the acetabular component, and if the femoral neck, for example, impinges on the cup, that can also lead to wear at unintended surfaces. When we talk about polyethylene particle production and osteolysis, we need to understand that adhesive wear is the most important wear mechanism that results in osteolysis. Adhesive wear occurs when bonds are formed between two surfaces, such as the femoral head and the polyethylene liner, and small amounts of material are broken over time to allow movement between those two surfaces. Abrasive wear occurs when there's differential hardness between surfaces, or when you have third body particles trapped between two surfaces. While this is perhaps the most intuitive form of wear that we think about, this is probably less important than adhesive wear when it comes to osteolysis. Osteolysis, of course, is an important concept to understand. Wear particles, whether that be polyethylene or metal debris, are the driving force behind osteolysis. Osteolysis occurs when the macrophage phagocytizes submicron polyethylene particles. And it's important to remember the macrophage is the key cell in osteolysis when we're talking about polyethylene. That's different for metal on metal hips, and we'll talk about that here in a minute. The macrophage is the one that releases the osteolytic factors that ultimately results in bone resorption by osteoclasts. So the macrophage and osteoclasts are the two key cells involved in osteolysis with polyethylene. The osteolytic potential depends on a number of factors that I've listed here, including particle volume, size, and host factors. There is a so-called osteolytic threshold of 0.1 millimeters of wear per year. If you're under that amount of polyethylene wear, it's unlikely that you will develop osteolysis. Now, the osteolysis mediators are listed on this slide. They include the typical actors, TNF-alpha, IL-6, etc. Now, osteolysis looks like this on X-ray, and you should be able to recognize what osteolysis looks like. We see proximal osteopenia, as we did with stress shielding, but here we see endosteal scalloping. You can see more of this ballooning osteolytic pattern as opposed to just bone loss associated with stress shielding. Oftentimes, you'll see an end-bearing pedestal as well, and this can indicate loosening of the implant. Lubrication is important when we talk about total hip arthroplasty. There's really two major categories of lubrication. Boundary lubrication, which is where the asperities on each surface contact directly. The opposite end of the spectrum is fluid film lubrication, where the two articulating surfaces are separated by a lubricant, in this case synovial fluid. In reality, most hips have a mixed lubrication pattern where there is some separation of the surfaces, just enough to prevent severe wear, but the asperities do in fact come into contact. One of the proposed benefits of large head metal on metal total hips was that we could achieve this fluid film lubrication regime and reduce wear. So let's talk a little bit about metal on metal total hips. I think that this is a commonly tested item at this point in time and has a good chance of showing up on your test. There were a number of proposed theoretical benefits to metal on metal total hips. Reduced wear, increased stability, inability to fracture, and this improved lubrication regimes were all proposed theoretical benefits. The contraindications when we started putting in metal on metal hips included females of childbearing age, as the ions do cross the placenta, as well as renal failure. Now, we saw early on some of this data, some of these hip simulator data studies showing the potential for dramatically reduced wear with metal on metal hips, particularly large diameter metal on metal hips. But this did not pan out. We saw an increased early revision rate with metal on metal hips, and the reason for this is likely multifactorial, but there's no question that the in vivo wear rates were orders of magnitude higher than what we thought they would be based on the in vitro wear data from the hip simulators. And I've depicted here a couple of studies showing that the clinical wear was substantially higher than what we predicted with the hip simulator studies. There are a number of design features we've learned that are important to metal on metal total hip arthroplasties. One is this idea of clearance. It's important to get the clearance just right. If you have too little clearance, the head can seize on the cup. If you have too much clearance, you end up getting polar contact. Both of these are not advantageous and can lead to trouble. We also learned a lot about this functional articular arc and keeping the wear within the constraints of the cup. Edge wear occurs when the maximum area of wear crosses over the edge of the cup. This leads to a large increase in local contact pressures, increased wear, and breakdown of lubrication. When we look at retrievals, as is depicted on the right of this slide, we see that a number of failed hip replacements with high wear rates showed clear evidence of edge wear. Edge wear can occur when the hip impinges. It can occur with microseparation during ambulation and other activities, and it can occur with edge loading. Edge loading, again, occurs when the contact area, the wear area, is outside the limits or the edge of the cup. This may be due to reduced coverage of the cup. A lot of these metal-on-metal cups were less than a hemisphere. Steep inclination or a vertical position of the cup can also lead to edge wear. And finally, reduced clearance. Metal-on-metal failure rates have clearly been device dependent. We know that cup position is important, that vertical cups were associated with increased failure rates, potentially due to the edge wear issues, as I just mentioned. When it came to hip resurfacing with metal-on-metal implants, we found higher failure rates with smaller implants, typically female patients. The opposite was true with total hip arthroplasty, where we found that the larger implants actually had a higher failure rate. And this may be due to wear issues with the trunnion and corrosion, which we'll touch on later. So the clinical outcomes of metal-on-metal, clearly higher rates of revision. Multiple registry studies have confirmed that at this point. You need to understand a little bit about the local soft tissue reactions, the pseudotumors that have been reported with metal-on-metal bearings, as well as with corrosion problems. The adverse local tissue reaction seems to be an allergic type response in some, and in others it can be a direct toxicity problem. ALVAL is a histological diagnosis. It stands for aseptic lymphocytic vasculitis-associated lesions. This is a lymphocytic process which is similar to delayed hypersensitivity reactions. It seems to be more common in females and small components, although I think that's not quite clear at this point. Often in aspirating these patients we'll get no cells. It's all degenerative material, and a manual cell count is important when working up these patients. If you get a question on the test involving a metal-on-metal hip and you see a histological slide like this with a number of lymphocytes, it's likely that the question is leading you down the path of an adverse local tissue reaction or ALVAL response to a metal-on-metal hip or a trunnion problem. This is what the MRI looks like in a patient with a adverse local soft tissue reaction. We can see a number of cystic masses, sometimes solid masses around the total hip arthroplasty. Again, if you see an MRI with a metal-on-metal hip, they're likely trying to lead you down this path. This is what it looks like clinically. We see widespread necrosis, and what we're all afraid of in these patients is loss of the abductors, as that's a very difficult problem to solve. Hip resurfacing, the good of hip resurfacing is that it preserves the femoral bone stock. The bad is the unique complication of femoral neck fracture, this was seen at about 1%. The enthusiasm for hip resurfacing has certainly decreased over the last several years due to some of these metal-on-metal bearing problems. When working up the painful metal-on-metal hip, there's a couple of important points to remember. Number one is do not forget the standard evaluation of all painful total hip arthroplasties. Just because a patient has a metal-on-metal hip does not mean that their failure is due to that metal-on-metal bearing. So the typical causes for failure, such as infection, should always be investigated in these patients. When it comes to serum metal ion levels, we know that they're not diagnostic. Normal is somewhere less than 1 part per billion. When they get above 7 to 10 parts per billion, we start to get worried. But we know that that metal ion levels cannot be used in isolation to diagnose a problem with a metal-on-metal hip. We've seen some patients with severe local soft tissue reactions with very low metal ion levels and vice versa. The MARS MRI, or the Metal Suppression Protocol MRI, is the imaging modality of choice for evaluating a patient with a metal-on-metal hip arthroplasty. And I would say that in 2016, I would be very careful about observing a metal-on-metal hip unless the patient is completely asymptomatic and an adverse local soft tissue reaction has been excluded with labs and an MRI. The indications for metal-on-metal hip revision at this point are somewhat variable, although I'll tell you that high-risk patients include any patient who's symptomatic, any patient who has mechanical symptoms. Certainly a change in gait or abductor weakness is very concerning. A suboptimal cup position with a vertical cup is always concerning as well. High ion levels, over 10 parts per billion, and an abnormal MRI. I think any one of those things should prompt consideration of revision surgery. When it comes to revising a patient with a metal-on-metal hip, it's important to remove all recalled implants. Any necrotic soft tissue should be debrided. We do know that revision of metal-on-metal hips, unfortunately, is associated with a high rate of complications, such as dislocation, failed bony ingrowth, and infection. Taper corrosion and trunnionitis has received a lot of attention over the past few years. It's important to understand the concerns about the corrosion that can occur at the taper modular head junction. This appears to be a mechanically assisted chemical corrosive process. It may be related to head size and femoral offset. Cobalt tends to be elevated more than chromium. The end result of this can be an Alval type pathology, similar to metal-on-metal total hip arthroplasty, with pseudotumors and local tissue necrosis reported. This may also be seen in metal on polyethylene total hips, so this is not isolated to a certain particular bearing type. There has been a move away from metal hips towards ceramic hips in the past few years to try to alleviate some of these concerns. Corrosion is the gradual destruction of metal by reaction with the environment. There are a number of different types of corrosion. Fretting corrosion occurs when there's small cyclic motion between two surfaces. This can occur at any modular junction. When we talk about total hip arthroplasty and trunionosis, of course, we're concerned with the femoral head and the femoral neck junction. This can lead to disruption in the protective oxide layer. Anytime the oxide layer is disrupted, this can lead to further corrosion. Crevice corrosion occurs when a crevice is created. This creates local conditions that can dramatically increase the rate of oxidation. Galvanic corrosion is the one that we think about with batteries. This occurs when two different metals are involved. Ceramic on ceramic total hips have a number of advantages. This is the lowest wear bearing couple that we have. The wear debris tends to be inert and non-toxic. The disadvantages include fracture risk and squeaking. With modern ceramic on ceramic bearings, there is a very low incidence of noise and fracture, but it does remain a concern. Some of the older zirconia heads had phase transformation concerns that limited their long-term survivorship. Despite these disadvantages, I think there's limited enthusiasm for ceramic on ceramic in North America, one reason being cost. Ceramic or metal on polyethylene total hips. There is a theoretical wear benefit to a ceramic head on a polyethylene liner, although the clinical studies have not clearly shown an advantage to ceramic on poly versus metal on poly. As I mentioned earlier, some of the concerns about corrosion with metal femoral heads have led to some surgeons going away from metal heads to ceramic heads to alleviate some of these concerns. Hemiarthroplasty in 2016, I think, is really relegated to the treatment of displaced femoral neck fractures in the elderly. The advantage here is stability. Retaining the labrum in the capsule, repairing the capsule at the end may help with stability. Some of the disadvantages include increased groin pain, protrusio, and worse function over time. This is why with patients, younger patients in particular, who are active, we're doing more and more total hips for femoral neck fracture than we used to in the past. I think there's no good data to support using a bipolar head over a unipolar head. And younger patients, as I mentioned, or more active patients who have failed open reduction internal fixation of the femoral neck fracture should be treated with total hip arthroplasty. Let's move on to some of the complications we see after total hip arthroplasty, specifically periprosthetic fractures and infection. Neurologic complications are a common topic that are tested on exams. The incidence of neurologic complication in total hip arthroplasty is about 1%. These are predominantly sciatic nerve injuries. The sciatic nerve comes closest to the acetabulum at the level of the ischium, and the perineal division is most commonly injured. There's a number of reasons why. You want to know what a perineal nerve injury can lead to, namely foot drop, as this is a common way that this concept is tested. If you have a patient who had a total hip arthroplasty who had intact EHL function and they lose it on the night after surgery, that's an emergency. That patient needs to be taken back to the operating room. It's likely due to a hematoma that needs to be evacuated immediately. 50% of neurologic complications resolve. Hip extension and knee flexion decreases tension on the nerve. It's important to understand why that's the case. The converse is true as well, of course. If you have a patient who has sciatic nerve palsy, you want to decrease tension on the nerve. There are some specific considerations regarding complications after total hip arthroplasty. I've listed a number of associations on this slide that you want to be familiar with, and we'll walk through these. With sickle cell patients, we're concerned about early loosening. With psoriatic arthritis, infection. Ankylosing spondylitis, the concern is stiffness and heterotopic ossifications. Parkinson's patients have a particularly high rate of dislocation and mortality reported in the literature. Dialysis patients are probably the highest risk patients for infection after total hip arthroplasty. And I think that's somewhat obvious when you think about the recurrent venipuncture and potential for bacteremia that these patients face. It's no wonder that the infection rate is very high. Loosening is also a concern in dialysis patients due to bone quality. As I mentioned earlier, those patients that have been irradiated should probably be treated with cementless implants due to concern for lack of potential for bone ingrowth. although some of the highly porous metals have shown promise in patients who have been irradiated. Heterotopic ossification is more common in males. It has been associated with a direct lateral approach and potentially an anterior approach as well. You should understand prophylaxis for HO in patients undergoing total hip arthroplasty. It can be done with radiation. It's low-dose radiation, 700 rads, either within 24 hours prior to surgery or within the 48 hours after the operation. Indocin or other NSAIDs have also been used as a way to prophylax against heterotopic ossification. The literature has variable dosing methods. In general, you want to continue Indocin or other similar NSAID for 1 to 6 weeks after surgery. What you need to keep in mind is that there is no role for late radiation or medications. If a patient returns to clinic at 2 weeks or 6 weeks and they have heterotopic ossification forming, you don't want to irradiate them at that point or treat them with NSAIDs. At that point, you need to let the heterotopic ossification process run its course. For those patients who have mature heterotopic ossification, if they have pain or limited range of motion, then you can consider surgical excision. The Brooker classification is commonly used with heterotopic ossification. I don't think it's necessarily important that you memorize the particulars of this classification, but you should understand that grade 4 means severe ossification to the point of ankylosis, and grade 1 is the more mild heterotopic ossification that we may see that really does not limit range of motion or cause other problems. Limb length discrepancy, slight lengthening of the operative limb is fairly common after total hip arthroplasty. Most patients rarely notice this or there's any impact on function if it's less than 1 centimeter. Once we get above 2 centimeters of lengthening, we start getting concerned with nerve issues. Remember that patients may perceive a limb length discrepancy after total hip arthroplasty due to soft tissue differences or weak abductors, the so-called perceived limb length discrepancy that will resolve with time. Templating reduces the incidence of limb length discrepancy, and you should understand how to template a total hip arthroplasty. This is a patient with a perceived limb length discrepancy. Understand how to measure leg lengths with total hip arthroplasty, as you can see as was done here on the right. You can see that this patient did not have a significant change in their limb length after their hip replacement was performed. Iliopsoas tendinitis is a cause of groin pain after total hip arthroplasty. This is typically seen in patients who have groin pain with resisted hip flexion on examination. Make sure to exclude other causes for pain, including infection. What you may see on radiographic imaging is prominence of the anterior edge of the cup, as is depicted on this x-ray. An image-guided injection into the iliopsoas tendon sheath can be helpful to establish the diagnosis. Occasionally, it can be helpful in terms of treating the patient as well. If a patient has recurrent or problematic iliopsoas tendinitis, then the treatment involves revising the cup if it's prominent, or lengthening iliopsoas through a tenotomy if there is no anterior cup overhang. So if the cup is potentially contributing to the iliopsoas tendinitis by being prominent anteriorly, it should be revised. Polyethylene wear and osteolysis, this is a common a common topic that's often tested on these examinations. What I'll tell you is that you should always look at the radiograph and recognize eccentric positioning of the femoral head. As you can see in this case, the femoral head is not sitting in the middle of that cup, and that's due to polyethylene wear. If you get an x-ray that looks like this on the test, in all likelihood, the test writer is leading you down the road of polyethylene wear and osteolysis. When it comes to treatment of polyethylene wear, I've put a few pointers up on this slide. Number one, if the patient is symptomatic or has a massive lytic defect, then that patient in all likelihood needs to be revised. The most important part of revision for polyethylene wear is addressing the polyethylene particle generator, revising the polyethylene. If you have a well-positioned and well-fixed metal cup, then a polyethylene exchange is an acceptable treatment option. If the metal cup is damaged or is loose or is poorly positioned, then you want to revise the cup as well. The most common postoperative complication after revision for polyethylene wear is instability, and using a larger femoral head is advised or is advisable in these patients. Bone grafting is controversial. If it's an option, I would choose it on the test. I think it's unclear as to how much of the bone graft actually incorporates and whether it's absolutely mandatory. I've listed the incidence of total hip arthroplasty dislocation on this slide. There is some data suggesting the incidence is increasing. We know that the highest incidence of dislocation is in post-traumatic patients with very high rates of dislocation reported in the literature. When we think about dislocation of total hip arthroplasty, we need to think about patient factors, surgeon factors, as well as implant factors, and we'll walk through these. When it comes to patient risk factors, we know that females have a higher risk of dislocation. Certainly patients with neuromuscular problems like Parkinson's disease are very high risk for instability. Alcohol use has been associated with dislocation, and then any prior hip surgery as well also increases the risk. Treatment of dislocation, the initial dislocation is treated with closed reduction. A brace is somewhat controversial. A neomobilizer can prevent a knee flexion, and in the case of a posterior hip dislocation can be beneficial, and I think bracing is a reasonable option. For the early dislocator, that is the patient who's dislocated within the first 6 weeks of surgery, 2/3 of those patients will not dislocate again. Once a patient is dislocated 3 times, it's much like baseball, 3 strikes and you're out. This is when we start talking about with the patient about revision surgery. I've presented here an algorithm for how to identify problems with the unstable hip and how to treat the dislocated hip. It really comes down to identifying the problem and fixing that problem. The first question you want to ask yourself is, are the components malpositioned? If the components are malpositioned, then it's a very straightforward answer. Those components need to be revised and repositioned into an optimum place. If there is no component malposition, then you want to identify any potential causes of impingement, whether this be osteophytes or lipped liners, skirted liners, etc. If you can fix these things, then those things should be fixed. Upsizing the femoral head, increasing the jump distance, improving the head-neck ratio, all of these can be helpful in improving the stability of the hip. If you have no component malposition and no sign of impingement, then this is likely a soft tissue problem, specifically an abductor deficient hip, and this is probably the one indication on the test for a constrained liner. You should be able to assess malposition on X-ray. You can see this is a retroverted cup. The image on the right is a lateral of the hip. You can see how that cup is neutral to retroverted, and that should be easy to identify if given that X-ray. Conversely, here we see the excessively anteverted cup. On the lateral X-ray, you can see that that cup opens anteriorly. That cup is likely to dislocate out the front. You should be able to recognize those things on X-ray. The treatment for instability, again, comes down to identifying potential causes that can be corrected. If the components are malpositioned and there's impingement, correct those problems. If it's a soft tissue problem, increasing the abductor tension can be done through trochanteric advancement, increasing leg length, increasing offset, and then finally using a constrained liner if the abductors are truly deficient. Remember that increasing head size and increasing head-neck ratio is also important in improving hip stability. If you have a physician who has well-positioned implants, I think it's reasonable to upsize the femoral head, as we've mentioned, particularly in cases like this where there is already a large revision cup. Improving the head size relative to the cup can be helpful in maintaining stability. Constrained liners come in a variety of different flavors. You can see a few of these depicted here. The fundamental concept is that all of them hold onto the femoral head to try to prevent dislocation. They all reduce the range of motion to impingement, which is why these should not be used in malpositioned implants. They have been associated with high failure rates, and again, reserve this for patients that have true abductor insufficiency. Dual mobility femoral heads have received increasing attention and popularity in the past few years. This essentially involves placing a bipolar femoral head into an acetabular cup, which is essentially an unconstrained tripolar articulation. This does introduce increased numbers of articulations, which is always a concern. There's also the concern for intraprosthetic dislocation, where the inner femoral head dislocates from the outer femoral head. The benefits of this construct include increased head-neck ratio, increased femoral head diameter, and improved jump distance. Moving on to aseptic loosening. Aseptic loosening remains the #1 cause of long-term revision of total hip arthroplasty. As mentioned earlier, the cemented cup tends to fail at a higher rate than the cementless implant. With uncemented implants, look for femoral osteolysis. Serial radiographs can be very helpful in terms of looking for loose implants, both clinically as well as on your test. You should know that the typical symptoms of a loose implant are startup pain, the so-called pain with the first few steps that tends to improve. If you have a patient who has startup pain in the groin, that typically is a cup problem. Startup pain in the thigh, the test writer is taking you down the path of a loose stem. The radiographic hallmarks of loosening should be familiar to you. With the cementless stem, you're looking for subsidence, as you can see on this X-ray here. You can see where that stem started relative to the calcar and where it ended up. A pedestal also on your test is likely to be representative of a loose implant. You can see why serial radiographs are particularly helpful. When we look at a cemented stem, progressive radiolucencies, migration of the stem, and fracture of the cement mantle are all hallmarks of a loose cemented implant. On the revision side, when we're dealing with femoral bone loss, the Poprosky classification is commonly used to identify the severity of bone loss. I've listed that classification on this slide. Type 1 involves an intact metaphysis. This is like a primary total hip. Most femoral components, primary or revision, are going to be successful in a type 1 femur. This is encountered uncommonly in revision work. The type 2 femur involves metaphyseal bone loss. This is typically where we're bypassing the damaged metaphysis and obtaining our fixation distally in the diaphysis. A type 3 defect includes some diaphyseal damage as well. A 3A refers to the femur that still has 4 centimeters or more of diaphysis remaining. A 3B occurs when both the metaphysis and a significant portion of the diaphysis are damaged to the point where there's less than 4 centimeters of diaphysis remaining for fixation. The type 4 femur, those are the severe femurs that involve a non-supportive diaphysis. My tip for you in terms of the revision femur is that if you're in doubt about what implant to choose a cementless diaphyseal engaging stem, assuming there is diaphysis left, of course. As I mentioned earlier, in the type 1 femur, which is relatively uncommon, a primary total hip arthroplasty implant will work. For 2s and 3s, again, it's a cementless diaphyseal engaging stem. For type 4s, where the diaphysis is non-supportive, then we're getting into the allograft prosthetic composite or a tumor prosthesis implant. There are 2 very common stems that are used in revision femoral work. One is the extensively coated cylindrical stem. This has become less popular recently. It's a little bit more difficult to use. You do need 4 centimeters of isthmus required for fixation. These tend to be stiff cobalt chrome implants. The tapered fluted modular stem has increased in popularity in the past 10 years. This is a titanium implant. It's a little bit more flexible than the fully porous coated cobalt chrome implants. 2 centimeters of isthmus is probably required. Occasionally we can get away with even less than that. And the nice thing about these modular implants is that version and leg length can be put together independent of the distal fixation. So the distal stem obtains fixation. The proximal body allows variation in limb length, offset, and anteversion, which can be very helpful in terms of restoring biomechanics. Moving on to the acetabular side, acetabular bone defects come in 2 flavors. The cavitary bone defect, these are the small defects that are relatively easy to deal with allograft or autograft. The segmental defects are the ones that can impair the ability to obtain a stable cup. These are the ones that become challenging. If you have 2/3 of the rim intact on the revision acetabulum, a cementless porous coated hemispherical cup is perfectly appropriate. 50% of acetabular bone stock is typically required for this type of implant. This will be the majority of revision cases that the surgeon is likely to encounter. When we get into more significant segmental bone loss, then we need to start thinking about something else, especially if we have pelvic discontinuity. That's where we start getting into things like cup cages, custom cups, and allograft. A jumbo cup is typically defined as being greater than 62 millimeters in diameter in women and 66 millimeters in men. A couple things to remember with jumbo cups is that they have been associated with an increased dislocation rate. That probably should be no surprise. These patients have often had many operations. They have deficits in their soft tissues. There can be a significant amount of dead space around the implant, and you want to really maximize the femoral head to cup size ratio. So try to use the largest femoral head you can in these patients. Identifying patients who need something more than a hemispherical cup is important. If you see something like this, where you have massive bone loss and pelvic discontinuity, then you do not want to check the box that says hemispherical cup. This is where you need to do something else. Now, whether it's a cup cage, whether it's a plate, whether it's a custom tri-flange component, whether it's allograft, I think it's unlikely that the test takers will ask you to choose between those options. It's controversial. We don't necessarily know what the right answer is. But what they do want you to know is be able to identify the cases where you need something beyond just a hemispherical cup. I've depicted a number of different options on this slide, and again, I think choosing between these is going to be beyond the scope of the test. You should know about screw placement in the revision acetabulum. The danger zone is the anterior superior zone. This is the so-called zone of death, where getting a screw into the external iliac artery and vein can quickly lead to the patient expiring. This is an emergency, of course, so you want to keep your screws out of the anterior zone if possible, and be very careful in placing screws if you do end up using this zone. Again, it's the anterior superior zone is the zone of death. The anterior inferior zone puts the obturator artery at risk. This can lead to significant bleeding, but this is rarely life-threatening. Periprosthetic fractures, this is a commonly tested topic. The Vancouver classification is the classification most commonly used when we're talking about periprosthetic fractures. A Vancouver A involves a fracture of the greater or lesser trochanter. A Vancouver B is a fracture around the implant, and these are the ones that are most likely to be tested. C-type fractures are distal to the implant and can be dealt with using standard techniques. If you have a type A fracture of the greater or lesser trochanter, these are typically treated non-operatively with the exception of the displaced greater trochanter. These are the ones that we treat with open reduction internal fixation. Again, a type C, which is a fracture well distal to the hip, those we treat as you would any other fracture. When we talk about the type B fractures in the middle of this slide, the B1, B2, and B3, these are the ones where you're likely to be tested on. And this is how I would recommend that you deal with these fractures. Number one, ask yourself, is the implant loose or not? And the question will often lead you down the path. They will tell you if the patient had pain, startup pain in the thigh, etc. If the patient has a loose stem, then you need to revise that loose implant. You can't leave a loose implant. So that patient needs cementless distal fixation. If the stem is well fixed, then that patient should be treated with open reduction internal fixation. And then if you're revising the femur, you need to decide what the bone quality is like. If you have adequate diaphysis to obtain cementless fixation, then that should be your answer. If the diaphysis is inadequate for diaphyseal engagement, then that's where you need to use either heavy metal, a tumor prosthesis, or an allograft prosthetic composite. Remember that you don't need to revise well-positioned implants. If you have a cup that's in good position, you can leave that cup alone. This is a typical Vancouver B1 fracture. You can see a stable stem that was fixed with a plate and screws. Proximally, you want to use a combination of locking screws and cerclage wires or cables. In a Vancouver B2, this is a stem that's loose. This, again, requires revision of the stem to achieve stable fixation. Let's talk a little bit about the intraoperative calcar fracture. This is a common tested topic. If you have a small calcar crack, there's a number of things you want to do in surgery. Number one is remove the stem. Number two is make sure that fracture does not propagate past the calcar, past the lesser trochanter. Number three, cerclage cable or wire the femur proximally, as was done in this situation. Number four, reinsert the same stem. And finally, making sure that stem is stable. If that stem is not stable, then you need to use an implant that is stable. Now, if you put in a stem that's not stable, this can be the result. You can get an acute postoperative periprosthetic fracture. You can see subsidence of the stem. The stem is obviously loose. This needs stem revision to a cementless diaphyseal engaging implant. Let's talk briefly about periprosthetic fracture. This is a big deal in arthroplasty. We've identified a number of risk factors, patient risk factors for infection, including those listed here. Obesity, diabetes, etc. have all been linked with periprosthetic hip infection. Staphylococcus is the most common culprit in these infections. In the acute postoperative infection, think Staph aureus. If it's a more chronic infection, a long-standing infection, you want to think coag-negative staph. Strep is another common organism, but really anything you can think of can be implicated in periprosthetic fracture. One of the big challenges is biofilm on the implant. We know that this forms within 4 weeks, sometimes even less. And this can protect bacteria from the immune system as well as antibiotic treatment. This is why, for established periprosthetic infections, we often have to remove the implants to fully treat the infection. There are several different types of prosthetic joint infection. I've listed those here. You're likely on your test to encounter the either type 2 and 4, which is the early postoperative infection within the first month, or the acute hematologous infection in a well-functioning hip, or number 3, which is the late chronic periprosthetic infection. You should be familiar with the MSIS criteria for periprosthetic infection. I've listed that here. We won't go into it for the sake of time, but you should familiarize yourself with this definition. It's important to know what the aspiration cutoffs are for defining infection. In the acute postoperative infection, we're looking for a white blood cell count greater than 10,000 and a differential above 90%. In the chronic infection, the white blood cell cutoff is around 2,000 cells with a differential of 60%. Now, there's a gray zone here, and I would recommend that you just recognize a very high number and a very low number. The test writers are unlikely to ask you to differentiate between subtle deviations from these cutoffs. With the acute postoperative infection, you want to avoid starting antibiotics. Drawing labs and taking the patient for an IND is important if the wound is draining. You don't want to bury your head in the sand on these with these patients. Taking the patient back to the operating room if you've decided to retain implants is critical. CRP should go down over time if you're concerned about a patient and whether or not they have an infection, and the CRP remains elevated. This can be very concerning for a persistent infection. So how well does irrigation and debridement and implant retention work? Well, it depends on a number of factors. The bottom line is that some of the recent data has suggested that this is only successful in about 30 to 40% of the time. With chronic infection, we're typically going to proceed with a two-stage revision. Two-stage revision remains the gold standard for chronic infection in total hip arthroplasty. How do we do this? Well, we remove the implants, we place a spacer, we treat patients with 6 weeks of intravenous antibiotics, and then return when the infection is gone to reimplant the hip. Single-stage revision for infection, for chronic infection, is really the European standard. They do it more frequently than we do. I think there's some move to this in the United States, but at the moment a two-stage revision remains the gold standard. When it comes to spacers, whether it be in the hip or the knee, there's very little difference between a static or a mobile spacer. There is some data to suggest ease of reimplantation in mobile spacers and articulating spacers, but no difference in terms of outcomes, particularly infection eradication. When using antibiotics in cement, you want to keep the amount of antibiotics low if you're using it for a reimplant, less than 1 gram or less per batch of cement. If you get above that level, then we start getting into trouble with mechanical properties. So is there a role for antibiotic suppression? I think there's limited circumstances to try this clinically, and for the purposes of the test, I would stay away from antibiotic suppression for periprosthetic joint infection. When it comes to VTE and total hip arthroplasty, I think there's a couple of things you want to keep in mind. You want to be familiar with patient risk factors, which I've listed here. Remember that most clinical VTE events occur between the second and sixth week after surgery, and pulmonary events on the day of surgery are typically cardiac or fat embolism and less likely to be VTE. You should familiarize yourself with the Academy's guidelines for DVT prophylaxis. I've listed a couple of the key points on this slide. Similarly, some of the DVT prophylaxis pearls are listed on this slide. Recognize the mechanism of action of a number of these different medications. We won't go through all of these, but I think referring to this list before your test can be very helpful as this is a commonly tested topic. We try to stay away from transfusion after arthroplasty. We know that transfusion increases the risk for periprosthetic joint infection. A few things that have been shown to be beneficial include hypotensive epidural or spinal anesthesia, tranexamic acid. Both of those can be helpful. There's really no benefit to preoperative autologous donation for non-anemic patients. There have been a number of studies that have suggested this to be the case. Similarly, bipolar cellular electrocautery has not been shown to be of benefit in a number of randomized studies. Tranexamic acid has really become popular in the past few years. This is an antifibrinolytic agent that inhibits plasminogen. It's contraindicated in patients with active VTE or renal failure. And there's no evidence in the literature that it increases the risk of VTE. A couple of young adult hip pathologies that I want to touch on here as we wrap up. Number one is osteonecrosis. Osteonecrosis is a blood flow problem. You should be able to recognize osteonecrosis on an X-ray and MRI. There are some associations with osteonecrosis in alcohol, steroids, trauma, and sickle cell disease. And of course, the medial femoral circumflex artery is the main blood flow to the adult femoral head. There are a number of different classifications of AVN in the literature. What they all have in common is that when you get to stage 3 disease, you're involving either articular surface collapse or imminent articular surface collapse through the crescent sign. So if you have a patient that has stage 3 disease or worse, that patient gets a total hip arthroplasty. You should not check the box for any hip preservation option for a patient that has stage 3 disease or more. So hip preservation should really be reserved for those patients who have pre-collapse disease, as you can see here. Whether it's a free vascularized fibular graft or core decompression is controversial, and it's unlikely that they would ask you that on the test. When we talk about young adult hip pathology, the major categories here are femoroacetabular impingement and dysplasia of the hip. These are important from the adult reconstruction side because the majority of patients in North America probably have some degree of underlying impingement or DDH. And remember that these are two ends of the spectrum. On one end of the spectrum you have the FAI hip, which is overconstrained, that impinges. On the other end of the spectrum, you have the unstable hip, or the dysplastic hip. Now, femoroacetabular impingement is covered in the sports lecture. I won't get into the treatment options, the hip preserving treatment options for FAI, as these are covered elsewhere. When it comes to total hip arthroplasty, this is really an option for patients who have advanced FAI with associated arthritis. Certainly patients 50 years or above, total hip arthroplasty should be the treatment of choice. Talking about hip dysplasia, there are a number of anatomic considerations for the dysplastic hip. When we look at the acetabulum, I've listed a number of those anatomic variations on this slide. If you're going to remember one thing about the acetabulum, remember that it is excessively anteverted. Same thing on the femur. Remember that there is increased neck anteversion of the dysplastic femur. There are a number of other changes as well, as with the acetabulum that I've listed here. The problem with the hip dysplasia is that you have a reduced contact area between the femoral head and the acetabulum. This leads to increased contact stresses and, as a result, ultimately arthritis. Femoral head coverage radiographically is identified with a number of different measures. The most common one is the lateral center edge angle, or the Weiberg angle, as I've depicted here. Normal is about 25 to 30 degrees. You can see how this is drawn with a vertical line down to the center of the femoral head and a second line that goes from the center of the femoral head out to the lateral edge of the acetabulum. And again, if you have less than 25 or 30 degrees, you have an uncovered femoral head and likely a dysplastic hip. Should recognize that the anterior insufficiency is a concern as well. So this hip is not only shallow but excessively anteverted. You can see here we've depicted the center edge angle of Weiberg as well. It's important to recognize these features on X-ray. The tonus or sourcil angle is also a commonly tested angle in the dysplastic hip. You can see how that's depicted here. When you have less than 10 degrees, you typically have a typical hip. Above 10 degrees, once you get abnormal, you have a very vertical roof of the acetabulum, which is associated with dysplasia. A few treatment considerations for the dysplastic hip. Number one is arthroscopy is rarely the correct answer. Be careful choosing that in any patient who has substantial dysplasia. Remember that you want to address all pathology. Most patients with dysplasia have both femoral and acetabular-sided pathology that needs to be addressed. On the acetabular side, the periacetabular osteotomy is going to be your treatment of choice. Anytime you have the option to repair the labrum, do that. You do not want to debride the labrum if given the option. And then, just like with FAI, if you have a patient who has substantial destruction of the joint with arthritis or joint space narrowing, then total hip arthroplasty is going to be the treatment of choice. When it comes to the periacetabular osteotomy, there are a number of advantages to this osteotomy, which is why it has become very popular. It allows for a high degree of correction while maintaining the integrity of the posterior column. You can see that depicted here. The osteotomy, again, does not involve the posterior column and allows a significant amount of correction of the acetabular version and inclination. When it comes to hip dysplasia and total hip arthroplasty, the Crow classification is the most commonly used classification. Again, it's a little bit complicated. I wouldn't recommend that you necessarily memorize the classification, but you should recognize that a Crow 4 hip is the high dislocation. That's the patient whose femoral head is no longer in the same zip code as the acetabulum. That's the depiction here, as you can see in this cartoon. In those cases, when it comes to total hip arthroplasty, we worry about lengthening of the leg. The concern with lengthening of the leg, of course, is the nerve. If you stretch the nerve, it can stop working. Lengthening the sciatic nerve more than 2 to 4 centimeters, or approximately 10% of the total length of the nerve, has been associated with a sciatic nerve palsy. The way we treat this, or get around this concern with total hip arthroplasty, is to perform a subtrochanteric shortening osteotomy. So again, the patient with a Crow 4 or high dislocation needs a subtrochanteric shortening osteotomy of the femur at the time of total hip arthroplasty to avoid excessive lengthening and nerve concerns. On the acetabular side in hip dysplasia, it can be a challenge to find adequate bone to anchor the cup. High hip centers we generally try to avoid. We try to put the cup down in the anatomic position. Sometimes using a protrusio technique can be helpful, where we medialize the cup to achieve enough coverage. Bone grafting of the shallow socket is also a possibility. Typically, this is done with the patient's own femoral head. And with that, we'll wrap up the talk. I wish you the best of luck with your test. Feel free to email me if you have any additional questions. Thank you for your attention.